Hello and good evening, everyone. I, Simran Chaudhary, network journalist at Voice of Healthcare, welcomes you all and thank you all for joining in this for the chat show. Today, we're going to talk about hereditary cancer, navigating risk, empowering women, organized by Voice of Healthcare and supported by Cipla. Today, on this special occasion, which is observed as International Women's Day, with the theme of Inspire Inclusion. We should inspire others to understand and value women's inclusion. We forge a better world. Also, women themselves are inspired to be included. There is a sense of belonging, relevance, and empowerment. Collectively, let us forge a more inclusive world for women on this International Women's Day 2024. So together, let's help fight the good fight. And in today's session, we are going to understand about what is hereditary cancer in women and help women with the experts in this domain. Today, we have with us a set of eminent speakers who is going to join us for the panel. Let me introduce the panels amongst us. So, for the session, we have Dr. Aparna Shrivatsa, consultant medical oncologist at Sahyadri Narayana Multi-Speciality Hospital, Shimoga, Karnataka. Welcome, doctor.
Yeah, thank you.
Dr. Shruti Behal, medical oncologist and hemato-oncologist, Nanavati Max Superspeciality Hospital, Mumbai. Welcome, Dr. Shruti. Dr. Ankita Patel, medical oncologist and radiation oncologist, Apex Superspeciality Hospital, Varanasi. Welcome, Dr. Ankita. Dr. Dr. Jogamaya, Pattnaik, medical oncologist and assistant professor, Department of Medical Oncology, Kalinga Institute of Medical Sciences, Bhubaneswar. Welcome, Dr. Jogamaya Pattnaik. Dr. Jovita Martin, Senior Consultant, Medical Oncology, MGMCI, and Visiting Professor, Mahatma Gandhi Medical College and Research Institute, a unit of Sri Balaji Vidyapeeth, Chennai. Welcome, Dr. Jovita Martin.
Hi, thank you so much.
Dr. Balmika RG, Senior Consultant, Medical Oncology, Velmala Medical College Hospital and VMC, Speciality Hospital, Tamil Nadu. Welcome, Dr. Balmika ji.
Yeah, greetings everyone. Nice meeting all of you on this platform.
Thank you. Today, for the session, I welcome you all and congratulate every woman present on this panel. A happy International Women's Day. And we all are gathered here to empower each other to raise voice for our betterment and for the improvement of our life and society. For further, I would just like to hand over the chat to Dr. Aparna Shrivatsa. There, she'll take over from here.
Thank you so much.
Sorry, ma'am, but there's too much of background noise.
Ma'am, from my end or from others? I just have to check.
I don't know, ma'am, but yeah.
Yeah. Abhi, I think there is no.
Yes, ma'am. Now it's
I
fine.
think it's better now, yeah.
I would like to hand over this chat show to Dr. Aparna now.
Yeah. Thanks a lot, Simran, for that lovely introduction. And I would like to wish everyone, our viewers, as well as our esteemed panelists, a happy International Women's Day. And let's get started with our interesting topic of today about hereditary cancers. So, to decrease the confusion, we'll just follow the order of panelists, which was printed in the flyer. First, Jogamaya, then Dr. Ankita, Dr. Balambika, Dr. Jovita, and then Dr. Shruti, so that everyone will be knowing, anticipating that the next question will be theirs. Yeah. Okay. So the first, whenever someone gets diagnosed in our family, the family members, everyone will be in a state of shock initially. They always worry about what would happen to the patient, whether they'll sustain the treatment, whether they get cured. And once the patient's treatment is started, the family members always worry whether they are at risk of cancer too. And in some families where there is family history of cancers, they are all anxious to know whether they are at risk. So this is a very important topic for everyone in whose family patient with cancer is diagnosed. So let's start with our panelists with some very important topics about hereditary cancer. So, Dr. Jogamaya Pattnaik, madam, what is hereditary cancer? So, patients always ask you, right? What is this hereditary cancer?
Evening, Aparna ma'am. First thing is that I should tell you is that your smile is extremely infectious. I think it has infected. It must have infected by now everyone, and uh, and everyone should actually learn to smile like Aparna madam. So, and another thing I'll tell, madam, don't call us madam. We are just colleagues, senior, junior. So you can call us by our names. Third
Definitely.
thing is that to answer your question, ma'am, um, yes, definitely we get to be in touch with patients, specifically the breast cancer patients. In our OPD or when we start treatment of those patients, their attendants definitely tell us that our relative has got cancer. Are we having a risk that we will also get cancer or not? So hereditary cancer means that the cancer which is transmitted from to the other generation. So this happens only in the maximum 5 to 10% of the cancers. If I consider cancer as a whole, uh, that means some genetic predisposition is there. There is some genetic abnormality that gets transferred through the generations, and that is the cause of cancer. Of course, some may be carriers, some may be sufferers, but the gene is carried throughout generation by generation. So that is called hereditary cancer.
Yeah. So as we inherit assets and money from our ancestors, we also inherit these disease conditions from our ancestors. And so the next question is to Dr. Ankita. So what are the common hereditary cancers in women that you usually see in your OPD?
So, madam, thank you for the question. So, in our scenario, basically, we encounter breast cancers, ovarian cancer. So, these are the common cancer. So, if we specifically talk about the females in our area, so the first common cancer is basically breast and ovary. That is due to BRCA1 and BRCA2 mutations, which definitely leads to the increase in lifetime risk of development of these cancers. As madam said that the risk of hereditary cancer is 5 to 10% only, but if the individual is inheriting these mutations, then the risk of breast cancer, the lifetime risk of encountering breast cancer in these patients are 47 to 80%. Not only females, male can also have these mutations, and in those cases there is increased risk of breast cancer and prostate cancer and pancreas as well. Second most common is the correlation between colorectal and endometrial, which we see in basically Lynch syndrome, which is due to the mutation of some genes, which leads to endometrial, colorectal, ovarian cancer, and stomach cancer. So these are the most common cancer, and these are the most common mutations which we encounter in day-to-day life in our patients.
Yeah, thanks a lot. So, majority of our breast cancers, if I have to say that cancer is the emperor of all maladies, then breast cancer is the queen of all cancers in women. And as you said, we see not only in women but also in men. So, our next question is to Dr. Balambika. So, madam, in your practice, what are the hereditary cancers that you come across?
Uh, Hereditary cancers, again, as the previous speaker, ma'am, has told, breast cancer is the commonest, ma'am, and followed by ovarian and probably colorectal, that place.
Yeah,
And I have
absolutely.
not seen,
Yes,
I have
yes.
not seen much of prostate or pancreatic. hereditary cancers, though it's commonly mentioned in BRCA1 and 2.
Correct. So the next question is to Dr. Jovita. So, madam, what are genes and what are genetic mutations? So patients always ask us, right? So we tell them that it is hereditary. So they ask us, can you tell us more? What is it? How does it come? Does it come in blood? They always ask, right? Does it come in blood? So what are these genes and genetic mutations?
Okay. Now, in all of us, we have cells, multiple cells, or millions and millions of cells. So, all the cells, we have a center which is nucleus, and in that there will be DNA and RNA. So, the DNA and RNA are the ones which carry informations in the form of codons. And these genes, when they get wrongly sequenced, when there is a mutation, that is when a defect happens. And that particular gene mutation, if it happens in the germ cells, that is in the sperms or in the ovaries, it can go, it can spread to the next generation. So it becomes a germline mutation. If that mutation happens in an ordinary organ, some other organ, during the life of a person, it becomes somatic mutation. That does not go to the next generation. That happens in a particular person, and that might lead to some cancers. So this is in gist. And also one other point I wanted to tell you is, whenever we have a mutation, we have, just like we all drive car. So in the car, we have accelerator and brake. So the brake is the tumor suppressor gene, and accelerator is the oncogene. So when the tumor suppressor gene works properly, whenever any mutation happens, there will be repair in the cells, or the cells will be killed completely, so that the cells don't propagate with the wrong sequencing. But whenever the tumor suppressor gene is not working properly, then the wrong mutation will be carried on, and it will lead to cancer with cumulative accumulation of mutations. So the oncogene, which is the driver, it needs to work in the right manner. It cannot be overpowered. The tumor suppressor gene needs to work correctly and cannot be underpowered.
Yeah, that's a very exhaustive explanation. So, Dr. Jogamaya, madam, how do you explain to your patients? They ask you, madam, what are genes and what are these mutations, right? We usually tell, okay, see, you have got this BRCA1, BRCA2 mutation. So they ask us, what is it? So, how do you explain, ma'am?
Try to explain them in a very simple way, as Dr. Jovita has told already, that our body and our cells, they are made up of actually chromosomes. In those chromosomes, what will happen to us, how we will be by nature, how we will be of phenotype and genotype, everything is written in there in those chromosomes. So if any problem in those chromosomes, and day in day out there occurs some defects in those chromosomes, and if they are not corrected, then we get some defective genes. If those defective genes are passed on generation by generation, then they cause actually hereditary cancers. So this may cause cancer. You may be suffering with the cancer, or you may be just carrying the gene. So this depends whether you will suffer from that affected gene or not. That will depend on several other factors. And most commonly, breast and ovarian cancers we see as those, and colon cancer, as already Dr. Balambika has already said, that these are the common cancers which we see. Most of the other cancers, they do not have this genetic kind of thing. So we should not worry about that. If any family history or multiple members in family are suffering from multiple type of cancers, or same cancers happens in many generations, then definitely there is a risk. So you should be worried about. If one person is affected, then it's no need to worry. We will calculate whether it is average risk, or it is moderate risk, or it is high risk. Then accordingly, we can tell you whether you need any screening or not. That only I tell you.
Yeah. So, as you rightly pointed out, that genes are not everything. Just because someone has a mutation, that does not mean that they will definitely develop cancer. And there is this important domain of epigenetics, where it is not only the seed, the soil, the nurture that the bad gene gets. That is how it will express. So we see so many of our patients with mutations, none of their parents will have cancer. So even if they are carriers also, they wouldn't have expressed cancer. So it is our lifestyle, maybe our eating habits, and our not only the genetic predisposition, but there are so many other things which actually help in gene expression also. So let's move on to this next question, to Dr. Ankita Patel. So, how does a female develop hereditary cancer? So a lady comes and she's diagnosed with breast cancer. They always ask us, right? The moment they're diagnosed, how did I get it? Is it what I ate? Is it my karma? Is it a sin that I got cancer? So if a lady gets a hereditary cancer and asks you, how what is the cause of it? So how do you tackle such situation?
Ma'am, if the patient is coming upfront with the diagnosis of breast cancer, so first we have to analyze the risk. So there is no single factor where we can pinpoint, okay, this is the reason why you got the cancer. It is basically the interplay between the genetics, your lifestyle, environmental factors, etc. So if we specifically talk about the breast cancer, yes, if the patient is having the history of multiple cancers or recurrence, or maybe a similar kind of cancer, or CA ovary, or CA prostate or pancreas in the family, or cancer affecting many generations. So definitely we can go ahead with the genetic testing and counseling. If no, then definitely there are many other causes like obesity, or not breastfeeding, body weight, other environmental factors, and like alcohol, smoking, stress. So in short, there is no single pinpoint concrete answer for this question. It is basically interplay between the genetics, environmental factor, physical activity, yeah,
Yeah,
and dietary habits.
that's yeah. So sometimes we don't even understand what caused cancer. So many people would have, so many women would have breastfed, and they are actually very fit and very physically active. Their
Yeah,
body
ma'am.
weight is good, but still such patients do develop cancers. So the next question is to Dr. Balambika. Actually, this question is not there in the list, madam, but sometimes a patient comes to you, we may not have a genetic counseling in our team, right? Some many hospitals will not have a genetic counselor in the team. So how do you usually assess that a patient, say breast cancer, a lady with breast cancer comes to you, and how do you assess, could it be hereditary or it is non-hereditary?
Yes, ma'am. This is a very important question. But we usually suspect hereditary breast cancers when the patient is very young, or she's having a triple negative histology, or there is any family history of breast or ovarian cancer. But prostate and pancreatic cancers, most of the patients will not be able to tell even if the family members had. They'll just say, my grandfather had an abdominal cancer, something like that. So now I think the recommendation is to universally test for all the patients, all the breast cancer patients for BRCA mutation. But usually the triple negative histology and young age and family history usually are the red flags, which trigger me to get a genetic test. And regarding the counseling, we also don't have a genetic counselor in our center. I do what, to my knowledge, they sort of preliminary pre-test genetic counseling, and I tell them we have to interpret the results with a pinch of salt. We have to carefully analyze whether the mutation detected is pathogenic or not. So I do a part of this, and I usually go for a genetic testing, which includes a pre-genetic counseling, so that patients are not misguided.
Correct, absolutely. So just because our hospital doesn't have a counselor, it doesn't stop us from suggesting genetic testing to patients. And most of the labs they do this tele genetic counseling, and they usually guide the patients because if I do the testing and the test comes positive, it is a big blow to the family. All the children, grandchildren, they're all worried, so it's very important to get a genetic counseling done, and many of the labs they are doing this tele counseling. So let's move on to our next question to Dr. Jovita. So what are the risk factors associated with hereditary cancer? So usually, suppose a patient with breast cancer comes to you, and she is detected with BRCA1 or BRCA2. So how do you usually tell them that what are the risk factors associated with this hereditary cancers?
Okay, so if a person comes with a breast cancer, what will be the risk of other cancers? That's what you mean, isn't
Yes,
it?
absolutely. So that's the difference between having a sporadic, just a non-genetic cancer and a genetic hereditary cancer. So yeah,
Yeah.
that's what
So
I'm.
basically, what we are looking at is we are looking at a syndrome. So a hereditary, inherited disorder, just one gene is involved, then only breast is involved. But when a constellation of several symptoms, several organs are involved, then it will be called a syndrome. So we have several syndromes like that, named syndromes. I think Ankita have pointed out to it. We have hereditary breast ovarian cancer syndrome, where breast and ovary is at risk. Lynch syndrome, where breast, uh, endometrium, colon, all these organs are involved. Leaf ruminase syndrome, where soft tissue sarcomas, bone sarcomas, glioblastomas, breast tumors, all of these cancers will be high. Cowden syndrome. We have in Cowden syndrome, P10 is the gene that is involved, where again breast colon is involved, Peutz Jeghers, and hereditary diffuse gastric cancers. So these kind of syndromes, the patient who is got breast cancer, it doesn't mean that only breast is at risk. So the same patient may have the risk of developing, say, a colon cancer or a pancreatic cancer or something else. Like in BRCA2, pancreatic cancer also is at risk. In a male with BRCA mutation, prostate also can get involved. So the counseling needs to be comprehensive to help them understand it's just not one organ, it's several organs that may be affected.
Yes, madam. I think that is absolutely essential that we sensitize the patient. That's the difference between non-genetic and a genetic breast cancer. So our screening protocols also we have to monitor. We have to modify our screening protocol both for the patient as well as the family members. So they should understand that it's not only the breast screening that is required. Other organs, cancers in other organs may also be involved. So it's a very tricky situation. The screening is very difficult, as well as the anxiety level will also be very high, and patients need to understand, and they should be very careful regarding the symptoms that can appear because of various other cancer risk that they have. So the next question is to Dr. Jogamaya. Madam, do hereditary cancer come only from parents? Do they skip generations? So sometimes what happens is the patients, the health condition of the grandparents, we are not sure of what they died of, what cancer, did they really have cancer or not, because maybe 50 years back the technology wasn't that great, right? So they will tell you that there was no family history, right? So can you please tell the viewers about this skip generation, how this cancer, hereditary cancers can skip generations?
Yes. Actually, some patients, when we take history, we always take about family history, whether in family anybody has suffered anybody has died or anybody is living with cancer, and if they have developed cancer, at what age they have developed cancer. So we take this history, family history of malignancy when we see a new patient all the time. So, cancer, it doesn't mean that it will affect every generation. Maybe it's the first generation who had cancer. Maybe the person is not living now. Next generation cancer, but they can carry that deleterious gene. Because as previously discussed, if a person carries a deleterious gene, definitely the risk of developing that particular cancer is high. Like in BRCA1 and BRCA2 genes, the risk of developing a breast cancer with a breast cancer like BRCA1 or 2 gene is around 40 to 70% in her lifetime. But another 30% is there, chance is there, she may not develop that. So she is a carrier, but to develop the cancer, certain other factors are also there. So those factors, if genetic abnormality are accumulated, then that person is prone to develop that particular cancer. But it is not 100%. So gene, if it is carried through the particular carried through a particular family, then it doesn't mean that every generation will suffer. So there are it's little different from the genetic disorders of autosomal dominant disorders. Like in autosomal, some kind of autosomal dominant genetic disorders or some neuromuscular disorders are there, in which every generation is bound to suffer from that particular disease. So it's not same thing with cancer. If a person is carrying that gene, the previous generation may not have suffered, but has carried. The next generation may not suffer, but it is carrying the same gene. But the lifetime risk actually is there. So there comes the point how screening will help to detect these patients, people who are yet to develop cancer, how they can be screened, and the cancer, if detected, can be detected early stage.
Yeah, absolutely. I think patients and the family should understand that there can be skip the a generation may not have cancer. The next generation might be diagnosed with cancer. So the next question is about genetic counseling. So the question will be first to Dr. Ankita and then to Dr. Balambika. So, Dr. Ankita, can you tell us about pre-test counseling, and then later Dr. Balambika can tell about post-test counseling. So, when you decide that okay, this patient will should get genetic testing, so pre-test counseling, how would it help the patient?
So, madam, genetic counseling is very much required if the we detect the cancer in very young patient, or two or more separate cancer in the same patient, or the family history. Now, if we go ahead with the genetic testing, there are two scenarios. First, the patient is having cancer, so that can help in the treatment. If there is some actionable mutation, definitely that can help in treatment. Secondly, if the patient, or if somebody has come across the positive test in the family, so we can guide, and it can be helpful in prevention of the cancer. As I told before, that cancer is an interplay between genetics and environmental factor and the lifestyle. Also, if we know ahead, suppose if the patient is having BRCA1 and 2 positive, there are chances 45 to 80% the patient might have life will have lifetime risk of breast cancer or ovarian. The patient, because these patients are at a very early age, most of the time their family are not completed, so it is always advisable to complete their family. If done, we can go ahead, or we can advise prophylactic surgeries, or maybe over preservation or pre-implantation selection. So these are the measures we can advise in the patient who has not developed cancer yet. And the patient who has developed cancer, these mutations, if they are actionable, we can target the treatment.
So, absolutely, as Dr. Ankita pointed out rightly, that in today's world, we are not doing genetic testing only to do the genetic screening for the family. It matters a lot in the decisions taken for the patient, the patient's treatment, and the maybe the type of surgery we do, maybe the type of radiation that you have to give, and many of the whether chemotherapy, what chemotherapy will help, whether targeted therapy can be added. So multiple decisions can be based on the genetic tests. So okay, you have suggested genetic testing and it was done and it's positive. So Dr. Balambika, so now post test counseling, how is it important, and how does it help the patient?
Yes, ma'am. Post-test counseling, I think, is more important when the results are like variables of unknown significance and all are detected, because patient will still be more apprehensive. Something is positive. Will it affect my like cancer risk and all? So that needs proper counseling and telling them what is important and what is not. What are the things they have to take care, like screening, and if the patient is already diagnosed with cancer, like how it will affect her prognosis, whether she has to do dialysis if the BRCA is positive, and the available treatment options. Suppose if the patient is having a positive with the BRCA, probably she should go for a bilateral mastectomy, bilateral salpingo-oophorectomy, and all. So all that is done in post-test counseling once we detect the pathogenic variant. And if the result, like I already mentioned, variables of unknown significance and all are getting positive, we should at least counsel the patient saying this is not much significant. You need not worry, but you should go ahead with the regular screening recommended for the population.
Yeah, absolutely. I think post test counseling is more important, because the moment they know that they are positive, there is a lot of stigma and lot of, it's a big baggage for the patient. And I had a patient who was very sad that she has transmitted it to her children and her grandchildren. So she thinks that she is the cause, only, not only that she is suffering, that she is making the other people suffer also. So I think it's very important to give both moral support and also scientific information, that she is not the one who is giving it. She has just simply carried it. She has suffered, and she's just giving a clue to the next generation that they have to be very careful, and they would detect it in early stages if they are a little cautious and careful. So the next one is to Dr. Jovita. Madam, what is a common screening technique for hereditary cancers? It's a very general thing, so maybe you can take it up as maybe BRCA1 positive, BRCA2 positive, and maybe Lynch syndrome. So we'll just break it up. So BRCA1 and 2, you please go ahead and tell us, madam. Dr. Jogamaya can talk about Lynch syndrome, the screening for the next generation.
Okay.
Yes.
Now, madam, I would suggest. See, in our country, we don't have a set guidelines saying that this is what you have to do. But what it can be a very logical approach to this will be, any child who attains the puberty, from the time they attain puberty, they should be taught how to do self breast examination. So every month after the periods, right, 4 days after the periods, they can do breast self examination, teach them. And if they have any finding, they have to immediately come. That is the first point. Second point is, if suppose a person in a family is affected, say at 45 years, so 10 years prior to that, 35 onwards, the family members should be should be asked to screen. So the method of screening will be, obviously from 40 years only we will recommend mammogram once in 2 years or 3 years. But in a case when they are younger than 40 years, or when they have never been pregnant, in those cases MRI and sonomammogram is how we actually ask them to do. And based on the risk that we have calculated, we can ask them to frequent it either every year or 6 monthly or once in 2 years. So that will all be based on whether what is their risk score.
Yeah, absolutely. I agree with you that there are a lot of challenges with genetic counseling and screening, because there are not set guidelines, and it is even difficult to get the patient to the hospital, the family members to the hospital also. So we can tell them, okay, you do MRI, you do ultrasound every 2 years, 3 years, or every year, but the patients usually don't come back for the screening. So it's a challenge to both guide them as well as to get them to the hospital. The healthy individuals, they don't come to the hospital such easily, especially 25 years, 30-year-old ladies. They don't usually come very regularly. So there are a lot of unmet needs in this area, where we don't have national guidelines, and so many times we don't know what to do, but we usually do whatever is possible in our situation, because MRI breast is also not available in many of the centers. So we usually end up doing ultrasound. We do clinical breast examination. I think breast self examination, as you said, is the best thing to do starting as early as possible. So the next question is to Dr. Jogamaya. Madam, regarding colorectal, because we are talking a lot about breast cancers, colorectal cancers, say Lynch syndrome. So how do you usually advise screening for the family members?
So I presume that the patient or the family has been diagnosed to be carrying uh, genetic risk associated with Lynch syndrome. So how do we screen them or advise the screening? So first thing is that we have to note what is the age of the person who has suffered a cancer, uh, the youngest person who has suffered. Ideally, the screening age should be 5 years lower than that person who has suffered. For example, the youngest suffering person is 30 years, so the screening should start at 25 years. In general, as per the guidelines, the screening for Lynch syndrome should start between 20 to 25 years. Lynch syndrome comprises of various cancers, risk of developing various cancers, which can include colorectal cancer, gastric cancer, uterine cancers, ovarian cancer. These are the common pancreatic cancer. These are the common cancers which can happen as a part of Lynch syndrome. So the recommended guideline is to do colonoscopy, a full-length colonoscopy, upper GI endoscopy, and transvaginal ultrasound. Then for pancreatic cancer, actually the guidelines are not very clear. One simple ultrasound will also do. For ovarian cancer, we can do serum CA-125 levels in female patients. So these are the screening things which can be done, and this can be frequency can be every 1 or 2 yearly. And as we have already discussed, these are healthy individuals actually. So compliance issue will be the biggest issue in these patients.
Yes, and I think, as you said, absolutely, we suggest all of these testing modalities, but also with them, we end up telling them that the symptoms of these cancers also, what are the usual early signs of colon cancer, endometrial cancer, so that if there are any, if they are not compliant, at least they should get diagnosed early. So the symptoms of cancer also they should better know. So let's move on to the next question. This question is to Dr. Ankita. So what are the types of genes that are examined during genetic testing? So you already actually in your previous discussion you mentioned how it is helpful for treatment of cancer. So in the genes, when suppose a patient with breast cancer comes to you, do you actually test only for specific genes, or are you comfortable doing a set of genes, a panel of genes? So how do you usually test?
Ma'am, ideally it should be panel of gene, but because it's not just BRCA1, 2, there are other genes as well, like PTEN, ATM, RADS genes. But most of the patient go ahead only with practicality, seeing the practicality. Most of the patient usually go ahead with BRCA1 and 2. But ideally it should be set of genes. That will be always preferable.
Correct. So the next question is to Dr. Balambika. Madam, sometimes patients, as Dr. Ankita said, they do only BRCA1 and BRCA2 and it comes negative. but patient has a very high risk of genetic cancer. Maybe she has bilateral breast cancer or family history of breast cancer. So, how do you tackle such situation?
Um, I usually go for a panel, ma'am, but if the scenario which you said arises, probably we have to test for the other genes as well. And actually, to my knowledge, I have read somewhere saying if even the all known mutations are negative, the patient should be counseled to be more careful if there is a strong family history and get screened for that particular cancer which is detected in the family at an earlier age, 5 to 10 years before the index patient.
Yes, absolutely. I think these days we are having very economical testing modalities where we can actually go for a panel of tests, not to miss these rarer mutations which can be the cause of hereditary cancer. And sometimes, even with the extended panel of genes, also it comes negative. And I think such families should always be careful regarding the screening and early detection. They should know the signs and symptoms of that particular cancer. So the next question is to Dr. Jogamaya. Uh, Madam, how common is BRCA mutation in various cancers? So, uh, you may tell us about breast cancer, ovarian cancer, maybe gastric cancer.
Uh, the risk of breast cancer, what we see in our clinic, BRCA positive breast cancers, what we see in our clinic is, I feel it is 5 to 10%, between 5 to 10%. In ovarian cancer, it will be, I think, same around 5 to 10%. In pancreatic cancer, it will be less than 5%.
Yeah, so I think it depends on the kind of series that we are looking at, and especially in India, we don't get such data. Also, sometimes such data is very difficult to get. Only we get data from the tertiary cancer institutes, and actually in the community, what is the prevalence? We don't know. And he said that compared to the Western world, these hereditary cancer syndromes are more common in India because of inbreeding, and it's a very common practice that we see in India that marriages happen in the same caste. So it is said that it is higher, but we don't know the exact percentages, as Dr. Jogamaya said. So the next question is to Dr. Ankita. um, so what are the therapies for hereditary breast cancer?
Okay. So again, as I said, if the mutation are actionable, for example, if the patient is positive with BRCA1 or 2, we can go ahead with PARP inhibitors like olaparib, rucaparib, etc. And also there is good role of immunotherapy like pembrolizumab, nivolumab, ipilimumab. Yeah, so these are the common therapies which we are using in hereditary breast cancer.
So these days the treatment option is also sometimes decided by the type of mutations that patient has. So the next question is to Dr. Balambika. Uh, Madam, what's the relation of hereditary cancer therapy and fertility? Suppose a young patient comes to you, maybe she's BRCA1 positive, so her fertility is her concern. So, what is how do you can, I think you can just tell how the fertility of the patient gets affected in a hereditary breast cancer, especially BRCA1 or BRCA2.
Yes, ma'am. I mean, I have read only after this meeting was told, but the fertility is supposedly less in BRCA1 patients. Around 33% of the patients in one study were found to have a lower levels of anti-Mullerian hormones. So BRCA1 might affect fertility, so that needs to be told the patient, and probably we should advise her oocyte preservation or other methods. But actually the results are mixed. It's not proven beyond doubt that BRCA1 carriers are supposedly going to be infertile.
Yeah, I think the point is that a young patient has got diagnosed with breast cancer. So her fertility may be at there may be a threat to her fertility because of the treatment that we are giving. So, Dr. Jovita, I think you can elaborate. So, a young patient, say she's 30-year-old, she is married, but she doesn't have a child yet. You want to give chemotherapy. So, how do you try to preserve her fertility? So, how do you counsel them? What precautions do you take while giving chemotherapy?
Um, Dr. Aparna, what we generally do is we use the LHRH alongside of chemotherapy. So basically, when we use that, the fertility doesn't get affected. That is one point. The other point is if they are willing to do oocyte preservation, embryo preservation, and if they have the bandwidth for financial ability to do that, then we encourage them to do that. And there are people who have become pregnant and who have had children even after the treatment.
So, such young patients they face lot of challenges. Cancer is just the tip of the iceberg, and they're and thanks to the technology that we are able to do embryo cryopreservation today, and we are using these LHRH analogs, and we are preserving their fertility. And I'm sure we have all seen patients who have completed their treatment, and then they have completed their family also with the help of such fertility preserving therapies. So the next question is to Dr. Jogamaya. Madam, what is the survival rate in patients with hereditary cancer? So they ask us, right? Is hereditary breast cancer any different from the other non-genetic cancer? So is there any such clear-cut correlation between survival and hereditary breast cancer? You are muted, madam. I
Muted.
not able.
Sorry, sir. Am I audible?
Yes.
Actually, the survival of patients carrying the BRCA mutation are better compared to the stage matched non-BRCA mutated carriers, because mostly these patients, if I'll remove the stage part, most of these mutated BRCA mutated patients, they are diagnosed actually in early stage, and because of the BRCA positivity, they are more sensitive to platinum-based chemotherapy drugs. We have now other drugs for them. If we do not talk about, so their actually survival is better. Uh, Only thing is that they carry this gene, but their survival actually is better compared to the same stage patients who are not carrying the mutations. Definitely, they will have a risk of developing another cancer. That is one. And in my practice, I have seen few BRCA mutated patients, breast cancer patients, who are actually doing very good. Even if they are triple negative, they are actually doing very good. Their metastasis, the metastasis, the time to develop metastasis, all these things are actually late. So they have a good survival.
Yeah, so that's a very positive statement that the such families they don't have to be very disappointed and nihilistic about their whole outlook. It's really nice to know that they survive even better than the sporadic breast cancer patient. So the next question is to Dr. Ankita. What is the role of nutrition during management of this hereditary cancer? So I think for every cancer, nutrition is as important as chemotherapy or surgery. So in such patients with hereditary cancer, what efforts do you take to maintain their nutrition?
So, ma'am, once we decide to go ahead with the treatment, definitely the illness itself and the treatment, whatever treatment we are going to go ahead with, so it will have a toll on patient's nutrition. So, proper dietary counsel and proper dietary consultation of each and every patient undergoing any sort of treatment, be it radiotherapy, be it surgery, be it chemotherapy, it's mandatory in our clinical setting. uh, in case of radiotherapy we do deliberately so that the patient doesn't lose weight, because then again re-RTP and everything has to be done. So it is a protocol. Every patient undergoing any sort of cancer treatment will go ahead with the dietary consultation. So in diet point of view, we always advise high calorie, high protein diet, inclusion of more and more green, fresh vegetables and fruits, avoidance of red meat. And regarding the supplements, definitely these patients are deficient. So we do prescribe supplements like proteins and multivitamins. So that depends on the treatment the patient is going ahead with. We have to counsel the patient that the diet is an integral part of the treatment, because the patient is going to have side effects to tolerate, and to go ahead with complete treatment, proper diet is non-negotiable.
Yes, absolutely. And in this era of misinformation in the social media, so patients are bombarded the moment they get cancer. They get forward messages on their WhatsApp regarding the dietary. There are a lot of these diet gurus who spread misinformation that they shouldn't eat sugar, they shouldn't eat rice and such things. So it's very important, as you said, that dietary counseling and diet chart is a must for every patient. So the next last question is to Dr. Balambika. But there is another question, that last question to everyone. When Dr. Balambika finishes her question, you should all give a message to all the viewers, just one liner about hereditary cancer. So, Dr. Balambika, what are the latest technology relating to diagnosis of these hereditary cancers?
I would say the next generation sequencing tests, madam, which are available. Like in every hospital, I think the lab people are going and marketing. So NGS has been made available even in the nook and corner of the places in the country. So NGS is a breakthrough so that we can detect the mutations and then guide the patients regarding treatment and further family screening and all, and path inhibitors on the treatment path.
Correct. So earlier we were just looking for single genes and we were checking whether that gene is there or not. But now today we are doing the entire whole genome sequencing is also being done to not miss even a small thief hiding and causing this hereditary cancer. So that was wonderful. I think we had a very interesting and scientific discussion about hereditary cancer. So this last
Dr. Patel, can I just tell you one thing? There's something called as VUS. We all are aware of this variant of unknown significance. Just as you said, there is a person who has a definitive family history with several people in the family with the cancers, and then when we do the test, BRCA is negative, but there are some very rare genes which have come up, and we don't have the data for that. And for those patients, even when they go for genetic counseling, when they come to us, we don't have the answer for it. So they have to be motivated to keep in touch with the geneticists, and to see, look at the data, whether what is the update of that particular gene. So I just wanted to add that point.
Yes, absolutely. So VUS is a headache not only for the family, for the doctors, or but for the oncologist also, because such patients have a lot of questions and we don't have answers, as you said. But in the days to come, I'm sure we will know. As there are so many labs which are doing genetic testing in India, we will develop our own database of genes that are commonly seen in India, and as the data accumulates in the years to come, that VUS will get upgraded as a pathogenic or non-pathogenic, in the days to come. So it was a wonderful discussion. So before we hand over the session to the the voice of healthcare, so I want one-liners from everyone. So we'll start with Dr. Jogamaya. So, what would you like to tell a patient or the family who is diagnosed with hereditary cancer?
Hereditary cancer doesn't mean that patient will die of cancer. most of the hereditary cancer patients, they actually do well or better than their counterparts.
Wonderful. Dr. Ankita?
So as it's a women's day, so I would like to appeal all the women to invest your time and energy and in self care. That is not selfishness. Take care of your body, watch for your symptom, watch for your weight, take good diet, watch for your invest your time in at least 1 hour of exercise. And if you have any kind of symptom, be it a simple minor symptom persisting for more than 2 to 3 weeks, go ahead for a clinical examination. Don't ignore your body, don't ignore your symptoms.
Absolutely. Dr. Balambika?
Ma'am, I would say improve your awareness and live longer because I think most of the problems happen because of lack of awareness. So first, I think all the patients should be aware of all, I mean, many aspects actually. So I would say be aware and live longer.
Yes, I totally agree with you. Dr. Jovita?
I would say that a woman is an important pillar in every family. They have multiple roles as a daughter, wife, sister, mother, and so many, roles that they have to actually fulfill. So only if the women are strong, even in health wise, they can do a lot for the family and for the children and for the next generations. Therefore, they have to invest in their health. So I would definitely, my quote will be, feed your faith and starve your fear.
That's really very encouraging. So I would like to conclude.
Okay, so in continuation to our session, allow me to welcome Dr. Shruti Behal, medical oncologist and hemato-oncologist, Nanavati Max Superspeciality Hospital, Mumbai. Good evening, Dr. Behal, and welcome to the session.
Good evening, and thank you, Doctor, for having me here.
It's a pleasure.
Same
So
here.
now, without further ado, let's begin the discussion. So my
Right.
first question to you is, could you tell us about what genes are and what genetic mutations are?
So, genes are actually units of your DNA, which actually carry a lot of information of how your body forms, functions, and does things. Any mutation in this genetic coding can cause mutations and cancer. These genes can be passed from generation to generation, and that is why you have something called as hereditary cancers.
All right. So, could you also tell us that, like, of course, that they passed on and it plays a role in hereditary cancers, but could you tell us why probably genetic counseling is important? And, like, we also spoke about testing before in the session. So, how or what kind of genes are examined during these tests?
So, hereditary gene testing is important. Why hereditary? History taking. It starts actually from history taking, where you understand that a cluster in a family, a lot of patients are having cancer. So, like the case, the parents or the siblings or the children, that is how you actually find out these cases. They are very young patients who present with a more aggressive disease. By doing testing, we can give treatment options not only to the patient but to the other members of the family for early screening and prevention of cancers that we see. The common genes that happen depend on the type of cancer. For women, hereditary breast ovarian is a syndrome where you have BRCA1, BRCA2, PAL-B2 as the genes which are known to be germline. There is a simple blood test that you will be doing to detect these genes. The reports generally come in 2 weeks. If the index patient has these genetic mutations altered, now we can use some medicines which work fantastically to maintain the patient cancer free for a longer duration and prevent recurrences. Similarly, we know that this gene is mutated, so we can get their siblings, children tested so that they can go undergo early screening. In some cases, like breast and all, we recommend after family is complete to undergo surgical procedures for breast removal or ovarian surgeries after completion of family. The one that is very famous is Angelina Jolie effect, that she had got her bilateral breast removed because she was also having a history of BRCA. So these really help us to understand or prevent cancers in the family. Similarly, in females with endometrial cancers, there is something called as Lynch syndrome, where the patient can have a family clustering of endometrial and colorectal cancers. So for them, we do different kind of genes that which come in Lynch syndrome. They are MSI1, MSH2, MLS2 genes that we test in these patients. So it is, and it has to be done under the supervision of a genetic counselor, because there are a lot of ethical and other issues which are involved. Because now, if you know that some patient has got a genetic gene, which can have a propensity to cause them cancer in the future, and you're discussing them to remove their ovary or their breast, it is, I think, so a very sensitive topic when they even don't have cancer. They're absolutely normal, living a good life, and they come to know that someone in the family got cancer, and they got tested, and if they have that gene, I think so. It has to be done in a certain way, which is called as cascade testing, where you do it in a certain format. So, and you counsel these patients on why is it required, and obviously if you catch it early, you can achieve better cure. So it is essential to look into these.
Would you also like to add a note on some recent or latest development or advancements in technology or certain tests that have become available that actually help in detecting certain kinds of cancers earlier or so on?
So we have tests which pick up these genes well, which is called as next generation sequencing, which is actually a test which would expand your entire DNA of the patient, and even the RNAs, and even there are other parts in the DNA which we examine, which are red and red. So next generation sequencing, that is NGS, is fantastic as a test to get these mutations known to us and benefit our patients.
Thank you. Would you now, before concluding, I would request you to, if there's anything, any, particular thing you want to tell patients, people, our, audience that, maybe along the lines of screening or genetic screening that they should undergo. Would you
So,
like to share?
so there's this something which is very close to my heart. It may not be genetic screening, but because we are having International Women's Day, I would urge all the people listening to take back home two things from us. Is doing mammographies for breast cancer after the for screening of breast cancer. That means you're absolutely normal, and you just want to screen yourself for early detection and cure, because breast is the number one cancer. So mammographies by recommendation is after 40 years of age for all females, yearly till the age of 65. Similarly, I want to emphasize to give your daughters and children basically an HPV vaccine, because if you see the latest Globicon data of 2020, second is cervical cancer, which is 100% preventable by just taking a simple vaccine. So I think so, because it's Women's Day and we are celebrating this all out, and two things that we can prevent or catch at early stage. I feel mammographies and HPV vaccines is something I would tell everyone in the community to please go ahead and take it, because I feel that cervical cancer happens at the age of 25 to 40. That is when the patient walks to us in our clinic. So that is the time where they're getting married, or they are flying in their careers, and they're just pulled down with cancer, and it is a really bad one. So I would urge everyone to at least get screened for this. Screening for hereditary disorders should not be done without a consultation of a doctor, because you should have a case in the family. There should be a good family history to support it, and it should be done with a prior counseling and understanding of how things will roll in future, and when surgery can be done as prophylaxis, or just simply screening yourself with test will be more than enough. All those spectrum of options should be discussed with the patient and the family. So these are things that we really need to sensitize everyone about, especially women.
All right. Thank you, Dr. Shruti. That was really informative for sure. And I would like to thank you
Thank you so
for
much,
your
Dr. Preeti. A
time,
pleasure.
for coming.
Yes,
And
it's a pleasure. It's a pleasure. Thank you. Yeah.
Thank you
Okay.
so much.
Bye.
Bye.